Hey, this is our first Lunch to Learn of 2017, and we think it's probably going to be our best one of 2017. And also thank you for your patience for the lack of tables in here. This was the biggest sign up we've had in 3 years, so we thought we'd get those tables out of there so we could accommodate more people. Today's speaker, I'm sure most of you know, he came here in 1992 as the CEO. Prior to that, he was in the Methodist hospital system in Memphis. He is a native of St. Louis, and I'll say he's a product of Parkway School District, which is the finest school district in the country. That's where I also graduated high school. It's even special to have him here today because he is retiring in this fall. So we wanted to get him one more time to address some issues with this hospital and also health care in our country. So I'll give you Mr. Tom G.
Thank you. I appreciate the turnout today. It's great, and a lot of partners here as well, and from our hospital system, and hopefully give you some perspective on some things that are occurring right now. If you follow the news at all, you'll see that healthcare reform, the repeal of the Affordable Care Act, and some other things are really going to impact hospitals like ours in the next few months. And so this is an opportunity for me to kind of share with you what's kind of happening to Henry County Medical Center in particular, but also to rural community hospitals and to our nation as a whole in terms of what are we going to do about dealing with healthcare reform going forward. So appreciate y'all's interest in that. I'm going to have to stand up here a little bit behind the podium because they're trying to videotape this, but I'll want to move around a little bit. And I hope you can see the slides. Apologize if you can't. I'll try to make those, explain those as much as I can, because I'm going to share a lot of data with you about the local community, local hospital, that I think is important for you to have some knowledge and perspective on. This whole subject of healthcare, rural healthcare, healthcare reform, what to do about the Affordable Care Act is a very complex subject matter, and so I'll try not to bore you with it or confuse you too much and try to keep it fairly simple, but really want you to come away having a good perspective of the total picture versus what we tend to see on TV is a lot of bits and pieces of this subject that makes it sound like it's a simpler thing than it really is. So I'll try not to be political. I know this is a political issue when we talk about the Affordable Care Act. I'll try to make it more relevant to, what's that impact on the health care of our community? What does it mean to a rural community hospital? And then look at the big picture as what are we as a nation going to do about health reform going forward? Because I hope that I will be able to demonstrate to you that doing the same thing we've always done is really not an option or an alternative for us to go forward. At least in the long term. It might be something that would be positive on a short-term basis. So we'll see where we go. Just a few things. Of course, the hospital. And I want to just start out and not get too detailed about mission statements and stuff, but I think it's important for you to understand what Henry County Medical Center is about. We are a locally owned hospital. We are, the citizens of Henry County are the stockholders of Henry County Medical Center. And everything we do is focused on delivering value to our stockholders. So if we were a for-profit company and we had stockholders in New York City or California, our whole goal would be to return value to those stockholders in those locations. But one of the great benefits of Henry County Medical Center is it's locally owned. And we're here trying to improve the quality of life for the citizens of our community and to focus the services that we have here locally. So that's what our mission is, and we serve the region, not only Henry County, but Benton, Carroll Weakley, and Stewart counties. And I think that's important to put in perspective about what's the future of this hospital and how important is that. Our vision as a medical center is to really make a difference in our community and improve that health status. And I'll show you some startling numbers in a minute about that problem that we have to address. We think we can do that as well as any medical center anywhere for the things we do. We are a primary and secondary service hospital. We're not a tertiary, what we call tertiary, which is a specialty hospital where you do brain surgery and open heart surgery. We're not doing that, and we're not aspiring to do that. But for the things that we do, we think we can deliver that as well as any hospital anywhere. And I think the numbers will point that out, that we do excellent care here for the things we do. I can tell you we can deliver a baby here as well as they do at Vanderbilt, and we can do it cheaper than they can do it at Vanderbilt. So, you know, there's some real positives for rural community hospitals and the services that we can provide. So just perspective, this hospital was started in 1953. We were started by an act called the Hill-Burton Act. That was a legislation from the late 1940s after World War II to try to make sure that rural communities had access to health care. So we were one of those first 5 years of that act that put hospitals in rural communities. And if you look at the original Jackson General Hospital, the same architect built that hospital as built this one, and our hospitals were almost mirror images of each other. Of course, Jackson grew over the years as more of an urban center versus Henry County being a rural community hospital. So, but just to say that most of these hospitals were kind of built the same way, same idea, and they were built fairly inexpensively. Our hospital was built at a cost of $1 million in 1953. About 100,000 of that, about 10%, came from the local community, and the rest came from the federal government, again, to try to get health care in the community. Today, to put that in perspective, if you wanted to rebuild this hospital, it would cost you over $100 million to rebuild this hospital. So this hospital has grown tremendously over time, and the value of that institution is quite big. Just a couple things that I want you to know about our medical center. We are a top-performing rural community hospital. We have, just a couple years ago, were rated by an independent group as one of the top 10 best value hospitals in Tennessee. What that meant is for your dollar, you got quite a bit of services in terms of value, in terms of the quality of care that we provide, the cost of that care. I know sometimes when you get an ER bill, you may think differently of that, but in terms of that bill compared to other hospitals, it was reasonable care, and we provide a good value there. We also just received this year a 5-star rating by Leapfrog Group, which is one of the major rating agencies for quality of care in the country. And the first time we've been rated 5-star, up from about a 3-star. 3-star is kind of the average, but to get to 5-star is quite a feather in our cap. And then I'll talk a little bit about this later in the presentation, about our strength as a rural hospital. Out of 66 rural hospitals in Tennessee, we were rated number 5 in terms of our strength, in terms of our market, our quality, our cost, and other things. So just to kind of set the stage there. So why do we need rural hospitals? I think the most obvious thing is about 25% of the nation's population lives in a rural community. That's both a big number and a small number. It's a big number in that that's quite a few people that can't be unserved in terms of our nation. But it's also small enough that the 3/4 of people that live in urban areas tend to get all the attention, get the money, get the resources, and the dollars that get spent on healthcare in our nation. Most rural hospitals are low-cost providers, as I mentioned. We do things much more efficiently. We are small. We have people in our organization have multiple hats. In an urban area where you might have an individual doing 2 or 3 different jobs, we have one person doing those 2 or 3 different jobs. And so we do things more efficiently. We are reimbursed at a much lower rate, so we have to do more with less. We are often the largest employer in our communities, and that's the case in Henry County. We are the #1 employer in the county. And as a result, we become a major economic driver in the community. And then we provide access to critical services. And what do we mean by critical services? This is a list that the American Hospital Association has identified as the most critical services that a community needs to have at a minimum to have adequate access to. And #1 is primary care. That's your family doctors, your people that you get basic health services from. Psychiatric care is the next one. We're fortunate to have Carey Counseling in the area. We have the Lake Haven unit, so we're in good position there. Emergency care. We need access to care within minutes of an incident so that we get those care. And again, not every rural community has that now. Prenatal care. So obviously if you're having a baby, you really don't need to be more than 20 or 30 minutes from your hospital, or you are going to have potentially worse outcomes if a delivery doesn't go well. Transportation, you need to have the ability for ambulance services to get you to immediate care. You also need to have access to get to the doctor if you're somebody that doesn't have resources. Then you need diagnostic services, x-ray, lab, those types of things. Home care, some resource within the community so you can be cared for at home. Obviously dentistry is another big issue, although the hospital isn't directly involved in that. That is part of the healthcare system. And then the referral network is really the hospitals, and where do how do you get into inpatient care? You have to have a network to be able to have access to that. So those are things that we feel like every community should have access to, if not immediately within their facility, but to have those in their town. So what's happening right now with rural hospitals and hospitals in general is we're seeing a lot of hospitals going out of business and a lot of consolidation occurring. In 1974, we had almost 7,200 hospitals in the United States. That was the high point year for most hospitals. Just the most recent numbers I have is under 5,000 hospitals remain. Of those, 1,800 or so are rural hospitals. And of that number, then there's about 1,000 hospitals right now that are governmental hospitals like ourselves, and that's down from 1,700. So you can see a significant decline in the number of hospitals in the nation. In Tennessee, we have had 137 hospitals just in 2009, about the time of the recession that occurred. We're down now to 125, and we're starting to see significant closures of rural community hospitals in particular in the state. We're an average size hospital for the state of Tennessee, so we're not a small rural community hospital. Most of your smaller rural hospitals are about 25 beds. We're 142 beds. We're really in line with even with the urban areas in terms of a medium-sized hospital. So if you look at the area that we serve, which is Henry County, Carroll, Benton, Weakley, and Stewart counties, that's our primary service area. Henry County Medical Center is the biggest provider of services in that community. And about 25% of all people in those counties that seek care overall, they come to this facility for their care. The next three hospitals on the list are tertiary care facilities. You've got Jackson General, Vanderbilt, and St. Thomas, and so they're the next biggest providers. And they provide the specialty care, the heart caths, those kinds of services. And then you get down to McKenzie Volunteer, which is in Martin, Huntington, and Jackson Regional, which is in Jackson, as the next providers. So you can see as a community hospital, this is a very critical hospital in terms of that market and where people that need to get those primary and secondary hospital services reside. Why do we need a hospital here? If this doesn't convince you, I don't know what else will. But if you look at the health status of our community, Henry County is really ground zero for poor health in one of the poorest health states in the United States. Tennessee as a state had ranked upward around 47th and out of 50 states. I think we're improving. I think we're down in maybe 40 ranked, somewhere in that range. Still pretty unhealthy. But Henry County as a county out of 95 counties, we rank somewhere around 87th, 86th. So we have a fairly poor outcomes. And you look at the life expectancy in Henry County, it is a full 2 years less than the United States average as a whole. We have about 1,020 deaths compared to 923 in the U.S. We have about 20% of our population rates their health as poor. And that's just them self-rating without actually evaluating that. You can see we do have higher low birth weight babies. We're actually on the average for teen mothers, although that fluctuates from year to year. Actually, this past year was a very bad year for teen pregnancy in Henry County. That has started to improve, and So that kind of goes in cycles in the state. If you look at the #1 killers in our community, heart disease is #1, certainly very high. Cancer, stroke, chronic respiratory diseases, and then motor vehicle accidents. One thing I'd like to point out there is motor vehicle accidents typically are not in the top 5 in most communities, especially in rural or urban areas. But in rural areas, we have a lot more issues regarding preventable deaths, and motor vehicles is one of those. We have a much higher rate of that. If you look at the death rate compared to the state, heart disease, we have almost double the state death rate from heart disease. Cancer rates a little bit closer to the average, but still much significantly higher. Stroke rate is almost 3 times higher than the state rate. Chronic respiratory diseases is double, and you can see the motor vehicles significantly higher. So we have some really big issues on those major disease processes. And a lot of this is lifestyles and other food and things that we do, but it's really about getting people into the right areas of taking care of their disease processes, their chronic diseases, their medication access, their access to health care, and then educating them about their health status, which is really critical as well. So, kind of going on a little further about the importance of this hospital, I want to talk to you a little bit about the economic impact of the hospital as well. This is the number of jobs that we've created in the directly from this hospital over the past 20 years or so. You can see we've added, in 1992 we had about 520 people associated with the medical center. That rose in 2005 to over 1,000 people being pretty much working directly through the medical center. That was our high point before the recession. During the recession and with the subsequent Affordable Care Act and other things that are going on, we're actually seeing a decline now in our labor force as a result. And so we're down now to about 940. It's still significantly higher than it was back in the early 90s, but we're starting to see the impact of some of the things that are occurring in the reordering of the health reform process. So we've lost about 100 jobs actually in the last 2 or 3 years during that process. So there's also some other spin-off businesses that you might be interested in. About another 430 jobs are associated with spin-off businesses that have occurred in the community as a result of the hospital being here. So a lot of these services would not be here if the hospital was not here. And those are things like assisted living, outpatient facilities, chiropractors, mental health services, pharmacies, physical therapy services, home health, and hospice services. Those are all services that depend on a steady stream of people coming through the local medical system. So if you look at Henry County as a whole, just in Henry County, we have 13,000 people in the workforce out of the 32,000 in the county that live here. In the market that we serve, there's about 57,000 people employed, and directly employed, just from those conservative numbers that I've shown there, about 1,400 people are employed by the medical center or spin-off businesses related to the medical center. About 10% of the working force in the area. So I think it's important to know that if this hospital weren't here tomorrow, what that impact would be on the unemployment rate in our community, and it would be significant. So a lot of times when a hospital closes in a community, it can increase the unemployment rate by anywhere from 10 to 20%, depending on the importance or impact of that facility within their community. So it's not a small economic matter. It doesn't affect everybody in the room. What is the hospital? Oops. Okay. This slide kind of shows you a little bit about the financial impact each year that we provide directly to the community in terms of health services. And this is a busy slide, and I'll have to just hit the highlights. but about $17 million is directly infused into the community from services that we provide through this medical center. At the top is just community health. That's recruiting doctors into the community of new services that we provide, like screenings and those kinds of things, and outreaches that we do to the community. We have about over $300,000 that we provide in education through the different colleges around the area that we work with to provide nursing care, pharmacy, residency programs, x-ray training programs, and those types of things. We subsidize care in about over $2 million for things like chemotherapy, ambulance services, OB services, pediatric services. Those are all services that we do not make money on, and those get subsidized by the hospital. We make $18,000, $19,000 in donations directly to the community in terms of ball teams that we support, Chamber of Commerce events, and those types of things that we do. Community building is, again, that's recruiting physicians to the community pretty much. Then we get to the really big ones, the over $6 million in charity and subsidized care that we provide, and another $4 million in bad debt. Bad debt is kind of a misnomer. It's those dollars that people can't pay on their bill, but have had resources. They may have higher deductibles, may not be able to pay their bill because those have gotten so big that it's outstripped their resources, and so that becomes a bad debt versus charity. But those people really don't have the ability to pay that money back. And then we have a number that's, I'll talk a little bit more about, is almost $3 million a year that this hospital gets has to subsidize to pay for the Affordable Care Act. And as you hear about how do we make things go forward, one of the ways that the Affordable Care Act was financed was through reduced payments to hospitals, with the understanding that we would have more people insured in the country, and as a result of that, we would have more paying people coming to our hospital to offset those charity and bad debt numbers. So it's a little bit kind of confusing perhaps to you, but to understand that a lot of the costs around the Affordable Care Act are being financed by hospitals, and rural hospitals in particular have some pretty significant dollars that we're putting into the system. So what do we mean when we talk about health reform? Everybody looking at health reform is looking for three things to occur that have to kind of fall in balance with each other, and we call it the triple aim. You'll hear different groups describe that of reform or of providing health care. It's got to be a balancing act between access to care, controlling costs, and quality of care that we provide. So you can't have any one of those being out of whack without it impacting the other areas. So it becomes a balancing act of how you do that. But those are the three things that everybody wants to see in our system. That we have people can get the care that they want, that it's good quality, and it doesn't cost too much to provide. And then how best to deliver that is the big debate. Is that something that should be done through the government providing that care, or should it be done through the private sector? And then you talked about the whole insurance, and do we need to reform the whole insurance system? Is that part of the problem as well? So, as we talk about access, then what the real issue around that is the uninsured. People generally have access to health care through their employers' insurance, through the government, through Medicare, through Medicaid if they're poor. But there's a whole bunch of people, about 46 million before the Affordable Care Act, that did not have insurance. Now, out of that 46, some of those, about 10 million, are immigrants, aliens that do not have citizenship in this country. Those people still have access to health care through the emergency room. Those people will get care there, but they're not eligible for any other health care programs other than that. We have about 13 million that are young people who don't really access the system, don't really use the health care. Any of us that have 22-year-olds, 23-year-olds, they typically never go to the doctor and don't use much health care. Typically, they don't have much incentive to get health insurance, and most of them Then we have about 30 million who actually have access to care but don't take advantage of it. Either don't buy it, they don't want to spend the money on it, for whatever reason they don't think they need it. And those are people who are typically employed, but maybe don't have a lot of spare change to be able to buy their employer insurance, or they don't even sign up for Medicaid or some other program that they're eligible for. And that's surprisingly how many people do that. But then you get to the number that to me is the most concerning, that creates some of the biggest issues, and that's the 18 to 23 million that are really don't have the resources to be able to buy insurance. And don't take this number and think it's going to add up to 46, because some of these people fall into both areas. They could be young people that are not taking advantage of their health care, or they may be people that have access to insurance but can't afford it because they make a minimum wage. And so that's what we're trying to hit, is that 18 to 23 million people that we're trying to get access to care, so we can take care of their chronic conditions and give them access to services. So how do we compare uninsured to the rest of the industrialized world? Very poorly. About 15% of that 46 million don't have access to insurance currently. That puts us way out of whack with the rest of the industrialized world. We're the only ones that do not cover everybody in some form or fashion for their care. And I want to be real clear about the difference between universal coverage and government-run coverage. It's two different things. One is access to care, and one is government providing a single payer source. And that's not what I'm talking about. I'm talking about how do we get everybody in our community the ability to have access to care, and that's kind of a different discussion. We're at about 15.1%. Spain's the next closest to us at 1.7%. So where does healthcare dollar get spent? Real quickly, 30% in hospital care, about 20% in physician care, 10% in drug costs, but drug costs, I can tell you, are escalating exponentially right now. A little bit in nursing home care and some in administrative costs. And a lot of people think that administrative costs are what's driving healthcare costs, and it's really not. It's really a fairly small portion of the total dollars. If you look at the gross domestic product, and I'll try not to get too economic on you here, but this is really critical for our country. Right now we're spending almost 20% of the dollars for all the goods and services that this country produces is being spent on health care. So that is a critical number to think about. When I first started in healthcare 40 years ago, the first paper I had to write in graduate school was about the impact of the gross domestic product that we were spending on healthcare. At that time it was about 11%. And now we're up to almost 20%, and we're still having that same discussion, and so it's been a concern for many, many decades. So, kind of what does that mean? Compared to the rest of the world, we spend significantly more on healthcare at 16%. Next closest being France with about 11%. You can see Great Britain, Spain, Italy all spend less than 9% on their services. So the impact that creates is that we are less competitive in global competitiveness. We have about 5% of the average person spends that much money of their money on healthcare. We have inflation that's occurring in healthcare because of it, and it really costs real wages, benefits, and results in high insurance premiums as a result. So this is a slide you probably can't see very well, but it's a really shocking slide to me. Over here we have what is spent on healthcare in the United States. That's the 16% that we spend just on healthcare. Over here on this one at it's really $1 trillion. This is what we spend on food in the country. We spend twice as much on healthcare than what we spend on food for all of us to live on in this country. In the center is China, spending almost 1.4 trillion, is what all the goods and services that are consumed in China is. So we're already spending more on healthcare than they spend for all of their food, clothing, defense, all of the services in their economy in China. That puts us at a great disadvantage in terms of competing in the global economy. So why are these costs so high in the United States? It's the way we really got a system that gives us the results that we've designed the program for. We have the high uninsured to start with. So everybody in this room that pays insurance, a portion of your insurance goes to pay for that charity and non-covered pay that everybody that doesn't have insurance has, whether you realize it or not. And that could be as high as 30% of your insurance bill is paying for other people's insurance or care. We have high end-of-life care, so we spend a significant amount of money in the last year of people's lives in this country, and I'll talk about that in just a minute. We have high drug costs and other technology costs. We're a leader in those services, but we pay more for drugs than any other country in the world. We have a volume-based system versus an outcomes-based system. So if you look at the United States, if you come to Henry County and get a CAT scan done, and you go to Vanderbilt and get a CAT scan done, both those CAT scans are paid for, even if they were done one day apart. When in Europe and other places, it's expected that you use one CAT scan, and you're incentivized to only do one and get the same results that you would get with two, but you don't pay twice as much for. So it's really a system that rewards volume in our country versus what the outcomes are. And so if you look at what we spend in the last year of life, we spend for the people that die in their last year of their life on the Medicare program, we spend almost $35,000 per person on average for those people versus the $9,000 that we spend for those people that survive that year. So it's almost more than 3 times as much as being spent on people in that last year of their life. And about 25% of all the Medicare funds expended annually are spent on people during that last year of their life. And I'm not here to debate whether we should have hospice and palliative care. Those are things that I think should be introduced and have a serious discussion about. But people truly that die typically are going to use a lot of services no matter what their age is in that last year. But it points out that compared to other countries, we spend significantly more there, and we're less likely to put people into hospice care or try to work on the dignity of death versus putting people through a lot of torture during that last year of their life because they're having lots of procedures done, chemotherapy that probably isn't going to work, or other things that really make that end-of-life process much more difficult. So that is a contributor. I'll skip that so there's more breakdown of where those dollars are spent. So looking at outcomes in the United States, we are all the way down here in about 23rd place of industrialized nations, and if you look at worldwide, all countries, we're in about 37th place in terms of our life expectancy in our country. So for what we spend, which is a lot more than most every other country, we're not getting a longer lifespan as a result of that. Really interesting statistic that I saw was that if you take Chile in South America, and France and the United States, we all have a very similar length of life, but we spend twice as much as France on healthcare, and France spends twice as much as Chile on healthcare. So it makes you wonder, what is Chile doing differently than the rest of us? And basically, if you look at it, they spend all of their money on primary care. It's about intervening with people before they get too far down the road and too sick. And because they have so little money to spend on health care, they have to put it in a place that works the most for their population. And France is more of a government-run socialized system that's more efficient. That's where they spend theirs. And then we have our system, which is basically a free-for-all care. But we all get the same results for that kind of money that you're spending. So this one's kind of a hard one to do, and this is a little bit on the politics, but I think it's important for you to put in perspective where Obamacare and the ACA fall in the perspective. This is a kind of a continuum from left being the most liberal viewpoint of how to deal with healthcare to the most conservative process of dealing with healthcare reform. And these are the major healthcare reform efforts that have been made for the last 40 years, or maybe longer, probably 60 years, in terms of how people have tried to deal with these ever-growing costs. On the far left, you see government, payer, and provider. That is basically government-run socialized medicine. That's what they have in Canada. That is a system where everybody has to go through the same system. The hospitals, the doctors are all run by the government, and everybody has to participate and cannot go outside that system. That's the most liberal system. On the far right is the most market-driven, which is really the system we have right now. Everybody goes out, they get their insurance from a private insurer, and they pick their doctors, they pick the plan for the most part, and get their care in the marketplace. Those people that don't have access to the marketplace just don't get care, basically. Then if you move from the left to the right, the next one from socialized medicine is Medicare for All, or the Medicare program. That is a government-run program, but it is managed by different private intermediaries, limited number of private intermediaries. So when you're a Medicare recipient, yes, all that money is paid for by the government. You're in the program, you get the same benefits in Tennessee as you get in California, but you might be getting yours through Blue Cross of Alabama if you're in Tennessee, or you get it from Blue Cross in California if you live in California. So it starts to become more managed by private areas. Then you get kind of in the middle, and this was managed competition. This was the Hillary Care debate back in the early 90s about trying to move towards healthcare for all, but provided by a system of limited managed care organizations. And it's very similar in concept to what we do in TennCare now, where you have a government paid for health system, but it's managed by a limited number of managed care organizations. So in Tennessee, we have that Medicaid program that's managed by 3 managed care organizations, Blue Cross being one, United Healthcare being another, and Amerigroup, and one of those groups is the other. So that, again, becomes a little more controlled, but a little bit more towards the free market process. Then we get to subsidized private coverage, which is really what Obamacare was. It is a system of giving access to care to the uninsured, subsidizing that care so that those people can access existing programs in the private marketplace or through the Medicaid program, and that's how that was designed. And then if you go all the way into the right, you're in the system that we had prior to that, where everybody just bought their insurance and got their insurance every which way they can. So I show that to say that while we've had a lot of political rhetoric around this whole thing, Obamacare was really a fairly conservative program. It was trying to move to a little more controlled environment, but it's going to be very difficult for those people that are trying to redesign the program to come up with a more conservative approach that doesn't just take us back to what we had before. So I would just say, as you hear the debate on that, understand that you're most likely, and if we're going to continue to provide the things that were provided on the Affordable Care Act, you're going to get a lot of the same components that you had under Obamacare. We may just call it something different in the process. So the Affordable Care Act was, again, not belabor it, but it was really meant to provide insurance to people, to provide a basic level of insurance, and to provide that through Medicaid expansion and the private health exchanges. And it had the individual mandate, which required people to participate or be fined, and same with the employers. And then it was going to be paid by reduced reimbursement to hospitals and other penalties and taxes that were picked up by other groups like the different groups that provide technology and things like that. So the thing that to really understand in terms of Henry County Medical Center, as I mentioned, $3 million a year that's being spent. We have been already told we will have these cuts, $32 million over the next 10 years that will come out of this hospital to pay for the Affordable Care Act. So one of the things we're very concerned about as they repeal this act is that those cuts be reinstated unless they come up with some replacement plan that would offset those cuts. Otherwise, that would be the death knell for most rural community hospitals. So we have three kind of options facing us with the Affordable Care Act. One is to outright repeal and do not replace it. Let's go back to the old system. And to be frank, that would, if they took the cuts away for rural hospitals, that would actually help this hospital in the short term, because we would go back to being a volume-based institution where the more patients we do x-rays on, the more surgery we do, the better we get paid, and we probably do well for a couple of years. But I would tell you that that's not going to be a long-term viable solution for our country, and I think insurance companies are going to try to change that whole orientation anyway. Next, we could outright repeal and then redesign the thing over time. That's what some folks want to do, is just get rid of that act, and then we'll take 2 or 3 years to figure out what to do. But then you've got some real fallout from that, and I'll talk about that in a second. And then you can repeal and replace or modify the existing system, which is really the way that I think most hospitals would like to see that addressed in terms of realistic approach. And so we'll see what the powers to be actually come up with. But if you repeal this thing, it really impacts a number of groups. It impacts the health insurance industry, hospitals, all of us as individuals, and the state of Tennessee in particular as well. If you're an insurance company, just outright repeal without replacement increases premium costs tremendously, because right now the insurance industry gets quite a bit of subsidies to provide insurance to those people that can't afford it. And if that went away, you would see, and if those people were required to stay in the program with, say, no limit on pre-existing conditions or other benefits like being on your program until your parents' program until you were age 26. Those all have to be paid for. Those increase insurance costs, and those would come back to all of us in premium costs. Spreading risk gets to be a big issue. If we take away the mandate for people to be in the insurance products, then fewer people are going to be in that, and most of those people are going to be the sicker people, whereas the well people pull out of the program. And insurance survives based on spreading risk, and we won't be able to do that. There's this whole thing about purchasing across state lines, and I hear that as a couple of our legislators say that's the solution to the problem. If there's more competition, we would have people able to get insurance cheaply because they could go someplace where it's cheaper to buy insurance and buy it. But that, if people saying that don't really understand how insurance works, because like I said, insurance is spreading risk. It is trying to limit your risk if you're an insurance company. So what does that mean to Tennessee? We are an unhealthy state that has very poor health outcomes. And so if you try to say you're an unhealthy person in Henry County and you think, well, I can go to Utah and buy their Blue Cross plan there because it's a lot cheaper, and I go to apply to Utah to buy their insurance, they are not going to sell to me as an unhealthy Tennessean because it's going to increase the rates for the people in Utah. And I think people that don't really understand how that works across state lines and the community rating that occurs with how insurance companies operate, you'll find that that sounds good in concept, but in practicality, it's probably not going to work. Hospitals, big problems for us if we just repeal and don't take away the cuts, as I pointed out. It's very much endangering to rural hospitals because we rely so much on Medicare and Medicaid. In Henry County, 80% of our patients come from those two programs, so 8 out of 10 people are in the Medicare or Medicaid program, for which we get paid less than cost to provide that care. And we also have another 6% of our patients are in charity, so we only have about 14% of the patients with insurance that are paying full care. We have very high drug costs that are just going through the roof, and then we have high bad debt and charity. Individuals, I think you would see premium costs. I think you would see issues regarding how you would get access to insurance. You can't just sign up for insurance when you get sick and hope that that's going to take care of everything if you don't have well people in the program helping to defer some of those costs. There is a discussion about health savings accounts, which I think has merit. Would allow people to have accounts that they would put money into and contribute to pay for their health care going down the road. That's great if you're a disciplined saver. You know that from retirement savings, that people know they should save for their retirement, but they don't. And so the question is, if you had a health savings account system, would people put money into that? And then there's a question about, do you provide whole services or just catastrophic services for people? And I would say that you would have a hard time getting all the services if we roll back the program. Won't spend a lot of time on this. I think that, you know, if you don't do anything, you're going to have a lot of folks off the rolls, about 20 million. You're going to have the whole issue about conditions, pre-existing conditions, and children being on there. But anybody that says they're going to give you those three things and not do the rest are not understanding how the system has to be financed, and so that'll be a big debate. What do I see happening to this in Tennessee as a result of all this? I think we're going to see some major changes. One concern is we did not expand the Medicaid population here, so we get less dollars per recipient than they do in California, New York, New Jersey, Massachusetts. All those places expanded their Medicaid. And if the United States government goes to block grants to states, what are they going to distribute to Tennessee versus those other states, and will we have that accounted for in that process? So we're concerned about that. They are talking about block grants where they would just give the state X dollars for their Medicaid plan, and it would be up to the state to design their program. I suspect that's the way we will be going. Our concern is what happens down the road. Does the federal government then wash their hands of the state and say, well, we gave you the money, if you don't have enough, it's your tough luck, and you'll have to figure out how to make that work. So there's a lot of concern around that. We do have the Insure Tennessee plan and the TriStar plan, which are good starting points that Governor Haslam and I think it's Congressman or legislator Sexton had come up with, and I think those are good starts for our country, or our state, to try to expand, cover more people in our state. I hope that will continue to go forward. We're very vulnerable as rural hospitals because we rely, as I said, on government payers, and we have a low socioeconomic status. We have a very low wage index. We get paid only about 72% of what the hospitals in urban areas get paid, so that's a problem. We have a declining population that makes it harder for us to cover, and then we have an aging population that we're trying to deal with. So those are issues for us as well. I think I'll skip ahead to just kind of showing you where we stand right now in West Tennessee. This is about 2 years, the most recent available data, but it's about 2 years old, so I can tell you it's declined even further since then. But this is the profit margins for the hospitals in West Tennessee. And you can see at the top, Jackson General, big tertiary care facility. It's about 10 times bigger than Henry County Medical Center. But they had a profit back in 2014 of $18 million. I know from this year that they had a profit margin of about $2.5 million. So their profit has declined significantly during that time. There you can see regional hospital again in Jackson area, and you go on down. Henry County is about 7th. We showed $1.8 million profit. I can tell you that profit is gone right now. We're in the red right now because of, again, that $3 million that's been coming off of us every year. The last 3 years is impacting us. And so that's the top 9. Those hospitals are making some money. Then you start to get into the hospitals that are losing money. Decatur, Huntington, Lexington, Union City, McKenzie, Tipton County, all losing significant amounts of money. And then you've got Humboldt, Gibson, McNary, Haywood, and Methodist Fayette have all closed their hospitals. So in West Tennessee, we have a significant problem with the financing of these rural community hospitals. And I can tell you that's declining rapidly for all of us. A number of those that are losing money are up for sale. They're in danger of losing those. And you have to ask what's going to be the impact on their community when that happens. I can tell you when new industry looks at an area where to provide a new plant or a new business, they ask about two services. They ask about your schools and they ask about your health care. And so not having one of those major components is a major problem in terms of recruiting new business and industry to you. Where are we, Henry County? I think we're in a vulnerable situation in that we are seeing declines in our revenues. I can tell you our reserves, which have been pretty good. We had built up several $1 million in reserves to cover a potential time that we're going through like we are now. Those reserves are rapidly declining, and so we in a couple of years we will have gone through all those reserves, and we will be in a potential situation. But we're doing better than most. And as we look at the Hospital Strength Index, which measures the vulnerability of hospitals, we were ranked 5th out of 66 rural hospitals. So that tells you there's a whole lot of hospitals in this state, that's in Tennessee, that are in danger. We are ranked 5th in our market position, so we are in a good position. We have a strong place in the market, and we have patients that are coming here. We're full today. We've been full all this week. You can't get a hospital bed in the hospital, but we're not getting paid enough to pay for the care that we're getting. We are 7th out of 66 in quality of care, and we're 20th now in 66 in financial strength, and that's the one that concerns me. And that's a year-old data, and I think we're going to fall even further in that. So that's something that concerns us is trying to protect this hospital and this market going forward. So what are we going to be looking for from our legislators and others is a good system that is going to look at rural communities in particular and try to do a number of things. One is to try to address social determinants of health. We have a lot of people with a lot of health problems and a lot of social issues that they don't see in other areas. And we think that rural hospitals need more effort to try to deal with psychiatric issues. We need people to have home community-based services and support for rural community hospitals to be able to continue to operate. We think there should be global budgets for rural communities. There should be dollars set aside for particular regions to be able to provide services within those. We need access to emergency care. So those communities that are losing their hospital, what about their emergency room? Is there a way to continue to provide emergency service in that community? We need to have a thought through access of hospitals such as ours that can provide full range of inpatient care services. I would suspect, based on the current trend in West Tennessee, that there'll be about 4 hospitals, and I think we will be one of them, that will provide inpatient care as a regional hospital. That's where we are trying to position ourselves to be. I would suspect ourselves, Dyersburg, Hardin County, and the Jackson hospitals will be those facilities. And the rest of the hospitals will probably become more like outpatient and emergency services providers. So I'll leave it there and open questions. I think the message is it's really important that we continue to have a strong hospital here, that our country really needs to deal with the problem of health reform and obviously take into consideration that rural health care is really vital for our community and hopefully will be addressed in that process as well. Any questions or comments anybody has? Yes.
Thank you for this presentation. I think the ones here are thoughtful enough to understand what is happening in the healthcare. From a county-wide standpoint, you address the hospitals that are closed around here. And I think there's another one up in Scott County that's critical access. And if that continues that way, and hopefully this would look to be regional in this area here. But if the situation over the next few years maintains where don't make money or you lose money, what do you think we could weather a 3 to 4 year period of losing money and maintain ourselves? Or do we have to look in some other direction, particularly if the legislative hopefuls don't come through?
I mean, I think the short answer is I think there's always going to be a hospital here. I think we're so strong as a hospital, there will be one here. I think what becomes problematic for our institution is being a sole community hospital that doesn't have the access to capital and dollars that we would need to weather a prolonged period of losses, is that we would be forced to try to affiliate with a bigger system that could help us finance that. And I think that's, you know, we have to decide if we want to continue to have a locally owned and controlled hospital, which I think has been the reason we're as good as we are right now, versus becoming part of another system of hospitals. And so that's something that would be forced potentially if something isn't done to try to help rural hospitals. We're very desirable right now to other hospitals because we have so many patients that there are people that would acquire this hospital if they could, but we certainly are not looking to do that and don't want to have that happen. Again, if you look at the other hospitals in other communities like Martin and places that sold their hospital, they regret that they sold their hospital when they did, because those hospitals had declined significantly over the years. And it's because the big systems tend to put a lot of money into them, just enough to keep the doors open pretty much. So that's a concern for us. We're positioned to weather the storm for a while, but again, if we had to go 5 years or something with that, then I think that would be a major issue for us. So that's a concern. Now, the way things are going to be delivered in the future, if we get away from this volume-based care, that means that we're going to have to do more in primary care, more serving the population as a whole, and we have to look in rural areas to see do we have enough population to maintain full-service hospitals going forward. If fewer people are hospitalized and fewer people are put in nursing homes and more care is provided on an outpatient basis, then you've got to have a certain synergy to keep a hospital in business as well. So those are all questions to be answered. I maintain that because of travel distances and access to care, that there may need to be a system of rural hospitals that operate differently from a urban area where there might be more direct competition, that you might have to have a regionalized system that ensures that there is the right resources in the communities, and we just have to see where it evolves.
Do you have any idea the managed care organizations that are managing ACA and TeamCare, what percentage of profit they know on?
Well, it's all over the board. It depends on, there are ACA health exchange products in the country that are doing very well, that make quite a bit of money. Not so much in Tennessee, at least they've demonstrated that they are losing a lot of money, and it depends on how many people sign up that are well people and how many that are sick people that are getting signed up. And so in Tennessee, we have seen a lot of them drop out of the exchanges, so there's just really one provider in most areas right now. Anything? Now, I appreciate y'all's attention. Sorry for keeping you a little longer than I intended to. Thank you.
Thank you, Mr. G. Hope you all enjoyed that and feel a little bit more informed. And we're passing out some questionnaires. We are going to give away a couple of door prizes for y'all today. I can tell you the next Lunch to Learn is going to be February 24th. That's going to be Dr. Cutright. He's going to be talking about a new total knee procedure that we're going to be introducing at the hospital. In March, we're going to have Dr. Monette, the new director of the Lake Haven Geriatric Floor. And then in April, Dr. Faust is going to come back and talk about foot health. So we've got the next 3 months taken care of, and hope you all will keep an eye out in the paper for those coming up. If you'll just fill out your evaluations, put your name on the back, and we'll draw your name for the door prizes. Thank y'all for coming.
It did find out earlier, but then it was, man, I thought once you would get going, and then it snowed for some reason. I'm glad you figured that out if you had to wait for it. Get your You wanna hang around, or I'll get you. If you can.
Just take the, and you still have, well, you still have.
February 24th. Check to make sure, because he's a doctor. He's a doctor, he can change. Okay. Come see Thank you. Well, you keep it. See, I'm gonna pull, what you pull? You pull one for me.
Today?
Yeah,
Be gone for today.
I ain't gonna, bring home them.
Do another one? You got two to do.
Yesterday, he didn't have enough stripes, and Mike put some of his stripes on, and I told him I'd go back today. So I can remember this.
Oh, we lost.
I don't think they had names on them.
Chris Wimberly and Barbara Mobile.
Well, what you gonna do this
Thank you for coming. Thanks for putting up with us.
Didn't have my
A
mother.
little tighter. Thank y'all for coming. See y'all on 24th of February. Yeah, I can't remember what day it is.
Sunday, I went on Sunday.
You
I
too.
waited till the week, I had some errands before, my errands before, and finally got in the cruisers at 3
It's
o'clock.
actually Friday, Mrs. Moss.
Finally got out of there, and it was dark, foggy, it was awful rain.